My name is Ronnie Turner. I started working as an aide in '92 in a small nursing home in Estes Park, Colorado. From there, I started to do like more like a travel aid up and down the Front Range here in Colorado. And after that, I decided, well, yeah, I needed a home. So I applied at a hospital in Northern Colorado, and I've been there now for the last 25 years. My role, I'm a CNA here at the hospital, and my role right now, I do training on for the onboarding staff that come in. The training is an hour and a half, typically once a month. And then we also do a phase two training for anybody who wants to do the phase two. And the phase two goes deeper. And we have discussions about how to move patients and what equipment that they should be using and stuff like that. Yeah.
I am an internal medicine trained hospitalist. I have been a hospitalist for about going on 8 years after residency. I work with Midtown Inpatient Medicine, which is a hospitalist group in Denver, and we work with SCL hospitals. Inpatient acute medical care is where my passion lies. You know, you work with patients and families at their most vulnerable. You get to see them improve, you know, day by day. Over the years, as I've been doing this, you know, mobility was initially a curiosity. As I became more involved with various hospitalist-driven metrics, it became more of, you know, an active reality, no pun intended. Yeah, in my mind, as a hospitalist, we're at the bedside. We see the patients throughout their continuum of care. So we play an integral part in terms of advocating mobility, bringing it to everyone's attention, but also, you know, it should become our day-to-day workflow.
My name is Jamie Haynes, and I currently teach at Central Michigan University in the Doctor of Physical Therapy program. I've been here at this position for 5 years, but I've been in physical therapy education for almost 15. And my role, I'm an assistant professor, and I'm a board certified neurologic specialist through the American Board of Physical Therapies. So that's pretty much my role. I teach in the neurologic interventions course here at Central. I do a lot of community outreach with people with neurologic conditions, and have begun to integrate, this will be my 5th year integrating safe patient handling content and equipment into our curriculum here.
My name's Chris Kwan. I'm retired physical therapy assistant and nursing assistant, and I spent 26 years working at the hospital in various things: cardiac cath, telemetry, x-ray, and before that I was 4 years, I was a Navy corpsman. I was a medic with the Marine Corps, and I was an EMT, and I worked in with the Air Wing with the Marine Corps as an FMS corpsman and an independent duty tech for a while.
I'm an occupational therapist. I've been an occupational therapist for about 17, almost 18 years now. I've worked in a number of different settings. I've worked in outpatient, I've worked in inpatient rehab, home care. Most of my career though has been in the acute care setting. So, and within acute care, I started as a floor OT, spent a lot of time in the ICU, critical care, neurointensive care units, as well as I've been in management. So I've had kind of a nice overview.
Sure.
So currently I'm working as a floor OT who serves the ICU, as well as I'm our coordinator for our safe patient handling program at the hospital I work at.
We all know that functional status decline commonly accompanies hospitalization, right? Many people, especially those admitted to the ICU, face functional comorbidities or decline for even a year after hospitalization. Awareness is one of the key things that I see that would improve patient mobility and collaboration amongst the teams. Awareness that some of the common things, poor sleep, poor nutritional intake, it doesn't have to be the patient who has a fracture and can't move, you know, pain, polypharmacy, inappropriate orders, you know, bed rest on a patient that may not need to be on bed rest. These are all factors that play a role in affecting patient mobility, and they can all be mitigated by, you know, hospital-based early mobility programs. For somebody who lives independently, who does their ADLs themselves, I think we should encourage them to do as much as they can.
And from Dr. Haynes?
So I really see the nursing aspect is extremely important. Just like you said, the research shows, especially in ICU and acute care, that we need to get people up more often, and physical therapists can't be there more often. And so when we work as a team, the therapist is the one that's challenging that patient and is pushing the limits, is in really promoting recovery very specifically in that time frame. But we also need the nurses who are with that patient hours upon hours to reinforce that for us. And so if it's using equipment, if a patient can sit up at the edge of the bed, then they should be sitting up at the edge of the bed to take their medications or eating. If the patient can get into a chair, using the equipment to get into a chair to really follow through with the ADLs that they're going to be needing to do at home. And so, I think that conversation is really important.
And let's hear from Ronnie.
Can you speak to how you build mobility into all the things that you do with your patient in a day?
I would say it's not a once a day task. With our heart patients, we move them 4 times a day. Everybody, because it's helping the circulation, it's helping the breathing, it's helping a whole lot of things. So once a day, when I hear once a day, no, it's not once a day. It's as many times as you can do it.
I have had family members say, this is too early. And so then we time out, we sit down and we have a conversation with education and involve the patient. And at our higher level patients, we'll say, do you want to get out of bed? And the majority of the time they say yes. They want to get out of bed and want to move. Their back gets sore, their hip gets sore, their shoulders, their neck. So they feel better getting out of bed.
So let's now pivot to why safe patient handling matters as we mobilize the patient.
I know that you have had experience both with caregivers helping you manually and with using safe patient handling equipment to help you get up. Can you speak a little bit to your experience comparing and contrasting what it's like when there are caregivers manually helping you and when they use appropriate safe patient handling equipment to help you?
Well, it's like night and day. For one thing, you can reduce the members of staff in when you have safe equipment handling and you're using it properly, because it's so much more relaxing for the patient to have less staff hovering around. If you've got 4 or 5 people on there, you do feel very uncomfortable because you're going, wow, I'm really big. It tends to be a real negative impact. Where you can't overspeak this is explain how the equipment works and say, this is a sheet. We never used a mobility sheet to turn people. Now we can do that. We can actually turn people every 2 hours. With one person, we never could do that. And it certainly reduces the stress on staff because you have more time with your patients. Mm-hmm. But also it's a confidence builder too, because there's something about when you've got somebody and you can slowly move them with a sheet and turn them, or you can use a lift to get them in an upright position. It's a real confidence builder for the patient to know they can extend themselves a little more and go, well, I can try a little harder because I won't end up on the floor.
What about the comfort and dignity of the movement itself?
Well, you have less hands on the person. So you aren't, when you're lifting somebody, there's going to be a part of it where you're using momentum and not control. You can move at a speed of the machine and it moves very slowly. Plus, if you're using a machine, you can look at the patient a lot more. If you're up close, you don't see the expressions on their face of pain, anxiety, things like that.
Early mobility is challenging because it requires the collaborative efforts of busy providers with different training, experience, patient responsibilities. So identifying these barriers has been the key in achieving success in this venue. So one big barrier is the fear that our patients will fall. Safe patient handling equipment is key because it allows our caregivers to maximize our patients' mobility while limiting that risk. So in our mobility pilot at SEL, we use walking slings and mobile lifts for patients with higher fall risk. We also use stand aids to get patients moving sooner. So knowing what safe equipment we have, which will mitigate injury to the patient and staff, is a great educational resource in terms of bringing safe mobility awareness to all.
I think it's helping each other problem solve as a team. Why, looking at the why, are there still barriers? How can we fix those? But I can tell you that safe patient handling has changed my practice. From a physical therapy standpoint, from teaching others, and that the immense positive that can come out of getting that very difficult to move patient or that critically ill patient to move again, there's nothing like it. There's nothing like it. And we can do so much more than what we could even 20 years ago. So I just hope people will consider that the joy that this can bring to really make a difference in someone's lives sooner, quicker, and then with less injury to any of us.
I think the equipment gives you so much more, and then with some of these patients without the equipment, I mean, you really can't do much.
We're very fortunate at our hospital to have a wide variety of equipment to use. So in our ICU, we have ceiling lifts, we have dependent transfers, lifts, we have electric sit-to-stands, we have manual sit-to-stands, and we have the friction-reducing slide sheets. So we've got a wide array of tools to use with our patients. I think of maybe some of our more obese or heavier patients that are quite dependent in the ICU traditionally are not moved as much as some of our smaller patients. And so I like to get the ceiling lifts involved for safety for us and for the patient the first couple times that they're out. So we may use the ceiling lift, and even if we're not sure if the patient will need it or not, for safety, we'll put them in the sling and have them sit at the side of the bed. That gives us a safe gauge for what they can do, and that will help transition. With our electric sit-to-stands, I like to do ADLs in those. Traditionally, we don't lay in bed to brush our teeth in the morning.
Sure.
So if I can get them sitting at the side of the bed and even standing in one of those lifts, depending on the lines and wires, if I can get them up to the sink or even pull the tray table up and give them an activity to do in standing, if they can tolerate it, we'll do that. And then progress them through to the manual sit-to-stands where the patient has to pull themselves up to stand, but they always have that pad there to be able to sit back down on and rest if they need to abruptly. They feel safer, we feel safer, and it helps to progress them through that activity, moving towards ADL that's meaningful.
If there are some watching today who are more inclined to keep their patient in bed because they're worried about harm to the patient by getting up, what would you say about that decision?
I would say it may be a disservice, an unintentional disservice. You may be surprised how easy and safe it is to use this equipment. And if you need resources, to reach out to the appropriate supervisors to receive education on using this equipment, because that may be a disservice to the patient in the long run.
Sometimes I hear people saying that mobility is therapy's job, that it's not really nurses' job to do mobility. What would you say to those people?
I would say it's everybody's job. We cannot wait for therapists to move people. It's part of your job too. We are a team, and unless there's something really, really bad with the patient and you feel as though you need to wait for therapy, then do so. But 99% of the time, we can do it.
And one more word from Dr. Patel.
Having that conversation, integrating that as part of our workflow. It shouldn't be up to the nurse only to have the patient sit at the bedside. I can encourage that. When I examine a patient, I can ask them to sit at the bedside. I can remind them that, you wouldn't eat your meals in bed at home. So why would you do that differently in the hospital?
If doing that screen, if that were part of the practice of every caregiver, every therapist, every nurse, every CNA, do you think that would have impacted your mobility when you were in the acute care hospital, when you were in the nursing home? What difference do you think it would have made, if any?
Absolutely. For one thing, it shows to me that the person that I'm working with, I has confidence in me, but I have confidence in them, because if they're doing a screening, they're actually interested in what are my limitations. They're watching what I'm doing. And you notice, what did that take? 30 seconds? That didn't take any time at all.
That's
And
right.
one of the things, caregivers, I don't have time to do that. And the time it took you to say I didn't have time to do that, you could have done that. I had the broken ankle. I was completely non-weight bearing for 6 months on this ankle. And then I had an injured wrist, but I had no problem transferring to commode. I would get myself in and out of the bathroom. I would take my own showers because I'm really motivated, and I didn't want to live the rest of my life at 57 years old, 58 in a nursing home. Mobility is not constant, it changes. There's days if the blood clots would be in a certain spot, and I don't know how exactly the physiology of this works, but if they were in a certain spot, I just couldn't breathe. And it had nothing to do with my weight, because once my blood clots, I was on a Coumadin regime, I'm not, because I had open heart, but once the blood clots cleared up, I was very motivated. I was motivated when I had the blood clots, and I think one of the things about doing an assessment daily is you can not only gauge the person's mobility, but also, are they motivated to work that day? Are they